Okay, so we have a baby boy who starts vomiting at 12 hours of age. The first two vomits were milky, but then subsequent vomits are green colored. The infant has not passed the meconium yet. The mother was well in pregnancy, but the notes show polyhydramnios. On examination, the pulse is 196, blood pressure 72/35, and cap refill 5. The abdomen is not distended, and there are no masses or tenderness or organomegaly. On the right, we have abdominal X-ray and chest X-ray, and also some blood tests. So pause the video. I'll give you 5 seconds for that and come up with a diagnosis. So the correct answer is duodenal atresia. So let's work this out together. So we have a baby boy who was just born at 12 hours of age. He is now. And the vomits are described as bilious, green. The mother was well, but except that it was noted that there was a bit of polyhydramnios. The abdomen is not distended. That's really useful bit of information. And there are no masses. Looking at the blood test results, we do see that urea is raised along with creatinine. So don't always jump on to say that this is AKI, acute kidney injury. Just keep it simple and consider things like dehydration. Okay. Looking at the chest X-ray, this is a classic sign of double bubble sign. There's one here and the second one here, which is characteristic of duodenal atresia. We're going through the options, so it says large for gestational age. We can rule that one out because it's not very specific. We would have shoulder dystocia, diabetes, or one of those nerve palsies called Erb's and Klumpke's palsies, where the brachial plexus, the nerves in the brachial plexus are damaged, and the baby's arm like is rotated in abnormal way. So we can rule that one out, and we don't see any of those signs in the history. Intussusception, we can rule that one out as well, because intussusception will have abdominal distension, described as sausage shape in the right upper quadrant around here, and the stool is described as recurrent jelly stool, and the babies have severe sudden colicky abdominal pain, and they have their legs flexed to their, or they have their knees flexed to their abdomen. Pyloric stenosis, we can rule that one out as well, because pyloric stenosis is described as projectile vomiting by the parents. Malrotation, again, this is not very specific and it's not a diagnosis, so we can rule that one out. Yes, malrotation, it can give rise to duodenal atresia, but it's not a diagnosis. So let's learn a bit more about duodenal atresia. So abdominal X-ray will show the bubble sign that we saw earlier. This is very, very important. So make sure you Google and see a few of those examples for yourself. This is due to dilation of the stomach and proximal duodenum. Polyhydramnios that we saw in the history is secondary to inability of the infant to swallow the amniotic fluid when in the womb. There's no abdominal distension in duodenal atresia, as the obstruction is in the upper GI tract. 20% is associated with Down syndrome. Now, the raised urea and creatinine are due to dehydration, which is again due to vomiting a lot. And how do we diagnose it? We do contrast studies to rule out malrotation and volvulus. Abdominal X-ray and blood test result to rule out infection. How do we manage? Firstly, we have to correct the dehydration by intravenous access. Again, the dehydration is due to vomiting. We do nasogastric tube to decompress the stomach and the GI tract in general, otherwise there's risk of perforation. Duodenal atresia is associated with heart diseases, and this needs excluding prior to surgery. And generally speaking, in these types of scenarios, you want to have a comprehensive assessment of the babies, because one abnormality is most of the time is associated with some other ones that could be missed easily. So I hope that was useful.